So today we are talking about three extremely important infections, three very important pathogens that include tuberculosis, diphtheria, and whooping cough. And as pathogens, Mycobacterium tuberculosis, Corynebacterium diphtheria, and Bordetella pertussis. We will start with tuberculosis. What is important to know about tuberculosis? It is also so-called poverty disease. So that means it will affect socially vulnerable layers of population. This is what makes this infection to be important, because as well as we know, on our planet we have more poor people, not wealthy people. Yes? The majority are poor. A lot of countries are developing countries. Not too much people have good conditions to live. So if you have a house, you're already a lucky one. If you have food on your table every day, you're already a lucky one. If you have health insurance and you can afford at least basic health support, health assistance, you are already the lucky one and making part not of majority but of minority. This is what is important to know. When we are talking about tuberculosis, if we make connection with a connection of infectious diseases, epidemiology, and microbiology, starting with morphology of a pathogen, you can keep in mind, or you can remind from the last semester, Mycobacterium tuberculosis, as well as pathogen that causes leprosy, Mycobacterium lepra, are acid-fast or acid-resistant microorganisms. This is due to their specific cell wall structure. You remember that Mycobacterium tuberculosis is gram-positive, right? Mycobacterium tuberculosis is gram-positive. Meanwhile, it is not really possible to apply gram staining to Mycobacterium tuberculosis because of an extra layer. So please don't misuse this extra layer with capsule. It is not capsule. It is an extra layer of mycolic acids. And why it is not capsule? Because classically capsule is considered an extra coat that covers first of all, usually it covers gram-negative bacteria, not all the time, but usually. And second, it is made of lipopolysaccharides, so basically carbohydrates. If we are talking about Mycobacterium, this extra coating is made of lipids, specifically mycolic fatty acids, that actually is a wax. So you must know that wax is a good protection. If we are talking, if guys could remind, if we want to protect the surface of a car, we cover it with wax. So it will be shiny and it will be protected from dirt and other stuff for a long period. Any other objects can be covered with wax in order to preserve, in order to give extra protection. So not just bacteria, not just Mycobacterium is using this substance for protection. This extra coat makes Mycobacterium tuberculosis to be extremely resistant in the environment. So if before we've been talking about the fact most of strictly pathogenic bacteria are very susceptible to the environmental factors, right? And conditionally pathogenic bacteria are more resistant to the environmental factors. When we are talking about Mycobacterium genus, this genus is extremely resistant for the environmental factors, including temperature difference, high or low temperature, including drying, including any kinds of radiation, of course in moderate amount. If we are talking about disinfectant substances and specifically antibiotics, Mycobacterium tuberculosis first is very resistant to a lot of them instantly, so it is natural resistance, and extra it can acquire resistance to antibiotics very easily and very fast. And Mycobacterium can acquire resistance to antibiotics to which it used to be receptive. This is why we need to apply a specific kind of staining for acid-resistant bacteria. And this method of staining is called Sill-Nielsen staining. You know it from the last semester. So the Sill-Nielsen staining, just to recap, has the mostly important part or stage of staining that makes the staining to be possible. And this stage of staining is called heating. It is not like carbolfuchsin is that strong that it is able to penetrate inside the cell wall of acid-resistant bacteria or any other dye, or you could remember we use 0.5% sulfuric acid in Sill-Nielsen staining. So even this sulfuric acid doesn't make Mycobacterium tuberculosis to get the stain. It just decolorizes non-acid resistant bacteria, and it keeps acid-fast bacteria will keep the dye. So the mostly important part of staining that makes the staining possible is heating. So we introduce this light with a smear into the flame. This, for a few seconds, these mycolic acids are melting, they become liquid, and the liquid dye penetrates inside of the cell wall. After that, we take it out, it gets cool again, it gets solid again. So when we decolorize it with 0.5% sulfuric acid, non-acid resistant bacteria will be decolorized, acid resistant bacteria will stay red. After that, we apply methylene blue that will help us to differentiate different cells under the microscope. So, what is important about morphology and physiology of Mycobacterium tuberculosis? That's clear. But they have also some cultural features, some properties that also make them different from other bacteria. First of all, you can observe the colonies will be R forms, yes? That means rough, they're not smooth. But it doesn't look like a classical R form. Yes? Because classical R form will be maybe even a little bit fluffy. But in Mycobacterium, it looks like a lot of small, extremely small S forms are gathering together. So they're a little bit shiny, but still they don't have regulated shape of colony. And it specifically looks a little bit, has aspect of maybe compared with cow's cheese. Yes? A little bit. And the same aspect will be in lungs when we are talking about pulmonary tuberculosis. When we have tuberculosis caverna inside of lungs, it is a place where Mycobacterium is multiplying and destroying the lung tissue. So it is closed with connective tissue and makes so-called tuberculous caverna. And the aspect of the contents of this cavity also will look quite similar. What is also important about cultural properties of Mycobacterium? They are slow growing. They multiply very slow. And when we are talking about slow multiplication, it can be up to 40 days or 6 weeks. So at least it will take 2 weeks, but very often it takes over 1 month. And if we compare it with other pathogens, usually that's enough 1 or 2 days to have a pure culture of bacterium. So you can compare how long it takes for detection or for cultivation of Mycobacterium. This is why when we make lab investigation of tuberculosis, we need to start doing everything at the same time. Like, we don't have time first to make pure culture, and after that maybe to check for antibacterial resistance, and after that to check for something else, because just for bacteriological investigation it can, in this way it will take up to half a year, and in this time everything could happen to a patient. That means instantly we apply all kinds of investigations. Instantly means we take the same specimen and we introduce it in different places. So we are making Sill-Nielsen staining. We are making cultivation, and at the same time we make cultivation on few culture medias. You can see here example of Levenstein-Jensen culture media that is specific for Mycobacterium, and it will be we will have few tubes of culture media. The first one will be just culture media, and others will contain different antibiotics we use in treatment of tuberculosis. And here is what we are talking about. If you remember, we've been talking about empirical treatment. Because if we are able to obtain the culture, if we are able to obtain the pathogen from a patient, what does it mean? That means it is open form of tuberculosis. And usually, yes, even if tuberculosis can affect basically any tissue and any system in our body, we are used to talk more about pulmonary tuberculosis. Why more about pulmonary tuberculosis? Because it is more common. Why it is more common? Because it is airborne. All of us are breathing all the time, not with breaks. This is why it is mostly susceptible system that could get infected with tuberculosis. So we can have different forms of tuberculosis. It can be tuberculosis of lymphatic nodes, thoracic, interthoracic lymphatic nodes. In this case, the person is infected, the person is sick, but the person doesn't present any risk and even doesn't need to wear the mask or to reduce its contact with society, with other people. It can be closed pulmonary tuberculosis without any eruptions, outbreaks in the environment. In this case, the person also is, let's say, conditionally harmless for society. But if we are able to obtain sputum of a sick person, and in this sputum we find Mycobacterium tuberculosis, that means this person is already dangerous for others. But there is a big difference between danger of getting infected with tuberculosis and, for example, flu. So we told that few sneezes here is enough, especially if I would be sick right now and I would sneeze for a few times. That would be quite enough to infect any person here. I'm not saying everyone, but potentially anyone would get infected, would be able to get infected. When we are talking about tuberculosis, usually will get infected the person that enters in the mostly close contact with the sick person and more times. Usually these are family members, usually these are maybe medical staff if they do not apply all the protection measures, and maybe neighbors, maybe colleagues from work, if the person is not aware or not letting others know. So you need close and repeated contact with the person in order to get infected. This is good about tuberculosis, right? That means just one accidental contact doesn't put you in a big risk. Even if pathogen will enter your body and you don't have repeated contact to get more and more contamination again and again from the source of infection, if you don't have any other issues, there is not a big chance for you to get infected. So your body is able to enclose the pathogen in lungs into a kind of calcium capsule, and nothing happens during your entire life. But the pathogen will stay alive there. So if something happens, it can erupt outside and it can produce an infectious process and disease. Now, in order to get sick, we need a lot of circumstances. First, as well as I told, it is called poverty disease. So the mostly susceptible population for tuberculosis are socially vulnerable people. Those without good life conditions, those who cannot afford heating all the time in any period, those who cannot afford good clothes, good food. Usually such people, not all the time, but usually such people have extra habits, negative habits, like alcohol and other substances. Usually such people, as a result, they have low responsibility level. That means they do not job, or they don't have job all the time. They don't have stable income. So all of these circumstances are just helping each other to make it worse. So if we take two people who are entering in the same level of contact with source of infection, but one is living in decent conditions and another one isn't, they from the beginning they are not in the same position in order to in what is saying about chance to get infected, to the chance to get sick. But it is not like you don't have a choice. You have. For example, there is a story about a man who've been put in prison. As well as I remember, it was in Soviet period, and that man was brought in Siberia, in prison there, and he was in a cell from which nobody were getting out alive, because everyone have been infected with tuberculosis in that cell. It wasn't warm there, it was high humidity, it was a lot of dirt there. So all the conditions to get infected with tuberculosis, and enough sources of infection as other prisoners who are already infected. So he got in a cell where from which nobody were getting out alive. Everybody have been dying from because of tuberculosis. But since that man used to be a doctor, he knew a little bit about tuberculosis. Everything he did, he's been eating everything he's been receiving, and he's been walking around the cell every day. He's been making circles in the cell. So, at least a little bit of food, at least a little bit of physical activity, movement, and you reduce the chance of sickness. It is just the first step. If you are making movement, and if you are not in prison, yes, you already have more choice. So even in prison you have a choice. You can just wait till death or to do something. So he's been the first one who got out from that cell alive, and let's say not too sick as others. And if you are not in prison, you already have even more choice, even bigger choice. So you can change something. The mostly unfair statement, there are some people who don't have any choice. Come on, I know a lot of people in worse conditions than a lot of us, and still they've been able to change something in their life. So, not everything is that bad. Now, how we detect tuberculosis? It is very important, especially in developing countries, in poor countries. It is very important to know how to detect tuberculosis. And the first sign of tuberculosis is cough, right? So don't be afraid. Not every time you can hear somebody coughing, that means tuberculosis. But if the person is coughing over 1 month, do you have such colleagues? If that person is coughing over 1 month in line, if that person is losing weight without visiting a gym, if that person has nocturnal sweating, if that person doesn't have good life conditions, and so on, there is extremely high chance it is tuberculosis. Not bronchitis, not flu, not something else. Yes, it can be extra, but the main issue could be tuberculosis. Is it treatable? Yes, it is. Is it easy to treat? Not that easy to treat, but still it is possible. So, good. We cannot detect too easily, especially lower social layers, right? This is why it is extremely important making a checkup among children in school. And I guess all of you made that test at school, did you? MAN2 test. It is a tuberculinic test that is introduced into the skin on the forearm, yes? And if it becomes larger than I guess over 1 centimeter and a half, something like that. That means there is a chance the person is infected. If it is not, the person is healthy. Now, it doesn't give 100% response, but it helps just to filter those who are not infected for sure. Why do we use this technique if there is one much more specific, that is X-ray? By X-ray, you can detect tuberculosis with precisely about 90%. So 100% will give you just lab investigation. But by the position of inflammatory process, you can already detect it is tuberculosis. So if it will be in the lower side of lungs or in branches, there is a higher chance it is tuberculosis. If it is here on apex, there is higher chance it is cancer. So there are a few features by which you can already detect by X-ray. Why don't we apply X-ray radiation for everyone? Or do we apply or not? Basically, that's okay if all of us once a year would make chest X-ray. And it is not really recommended to make it more than once a year if it is not a clinical necessity. So, why we start with this intradermal reaction? Because as much people we radiate with X-ray, as higher is the chance that one of them one day, because of this X-ray, will get cancer. So not all of us, yes, but as much people are supposed to that risk, law of big numbers. As bigger is number, is higher is the chance for incidence. This is why we want to reduce all the risks. It is first reason. And second reason is it is much easier to take one person, to send it at school, and to make maybe a few hundreds of injections, intradermal injections. It is much easier than including thousands of times X-ray machine. It is easier, it is cheaper, and it is more safe for population. So we should look wider in order to make the best for both population and medical system. It is very important. And by detecting kids, first of all, we reduce morbidity, especially among children. It is very important. And second, if you find a kid with tuberculosis, strategically it's very good, because that means it is not big chance that kid is having a social lifestyle, but there is a very high probability that this kid is from socially vulnerable family. So probably the entire family is sick. You find the kid, you find the entire family, you find all the contacts of this family, and you detect all the sick people. So strategically, it's a very good way to detect tuberculosis. As lab investigation, it depends on which stage and which nosological form of tuberculosis we have. So if we are talking the mostly spreaded one, pulmonary tuberculosis, of course we need to take a sample of sputum, and to make all the microscopical, bacteriological, serological, antigenical, and so on, all the investigations. Of course, the mostly fast one will be PCR test. Even faster will be antigenic test, but the PCR test will be more precise. And this is what gives us more advantages in comparison with previous generations in detection of tuberculosis, because before appearance of all of these machines, we've been making everything just classically by bacteriological and microscopical investigation. Now we have extra tools that are helping to find more specific features, including antibiotic resistance. That is extremely important in tuberculosis, because we have to reduce circulation of multi-drug resistant strains. Do you remember that classification, MDR, XDR, PDR, in resistance for antibiotics? So this classification is the mostly used in tuberculosis. So MDR means, let's remind, multi-drug resistance. That means at least for one antibiotic bacteria will be resistant. That means this antibiotic is making part of a group of antibiotics that makes automatically this bacteria to be resistant against more than one antibiotic for sure. It is multi. Everything that is more than one is multi. The second one is extensively drug resistance, XDR. XDR means backwards as MDR. At least one or two antibiotics will be efficient and rest of them will be useless. So bacteria is resistant for most of antibiotics, but few are efficient. And PDR is pan-drug resistance. That means total or universal antibacterial resistance. That means for this very case, not too much what we can do. Still, we have other ways of treatment, but of course the chance to treat such a person, especially if we are talking about tuberculosis, will decrease dramatically. So if we want to decrease morbidity and mortality with tuberculosis, we need to decrease circulation of resistant strains in the first, on the first place. Maybe it would sound tough, but it is much better to not treat the person at all instead of treating and not finishing. Because as well as I told, such people have very low responsibility level, usually, most of them, not all of them, but most of them will have low responsibility level. And sometimes, you cannot keep the person by force in the hospital. If the person decides to leave, the person leaves. And also usually such people are used to be sick during their entire life because all the time they have some issues. And they go to a hospital or they call an ambulance when it is very bad. So they get a little bit of treatment. After that they want to come back to their life because in hospital you never find things they have in their real life. So they, from the moment they feel a little bit better, they refuse hospitalization and they go home. In this case, the doctor could insist at least for ambulatory treatment. But you can imagine that that person will not be as such responsible in taking even ambulatory treatment. Even if you give to that person everything for free, it will be very hard to make that person to complete the treatment. So we had even... yes, it is very hard. Now imagine that you have a deal not with the disease, but with behavior. And we even had some programs sponsored by different organizations in which sick people, you just imagine, have been paid. Just come and take a pill. Would you like to be paid every time you're sick? Like, not too much, but please, as much as you are coming for a drug, for a pill, for antibiotic, as often you are coming, as often you will get a little bit of money for bus, for bread, for something like that. But you cannot continue that forever. You will still not change the behavior. It is very hard to do it even in responsible people. It is very hard, for example, for me to ask you to keep silence during the lecture, yes, and to get the result. It is very hard. And now imagine how hard it is to convince such people to get treatment. Meanwhile, both are for their sake. Right? Right. And for yours. It is a big issue. We can treat it. We must treat it. and we must stop spreading. It is very important to stop spreading. Now, how we treat, of course, with antibiotics, and we need to keep in mind that it is very important to pay attention, most attention to prevention. And if very often I say about importance of vaccination, especially when we are talking about airborne infections. In case of tuberculosis, frankly, I have doubts about importance of vaccination that much. And first reason is, please, this message, do not cut it from the context. Yes, I am not against vaccination, but specifically for tuberculosis, for sure we have better prevention methods. And first reason is we don't have species-specific vaccine against tuberculosis. We do not have vaccine against Mycobacterium tuberculosis. And if you are saying, but what about BCG vaccine all of us are getting in our childhood? BCG vaccine is made of also pathogenic species of Mycobacterium, but not tuberculosis. It is made of Mycobacterium bovis that usually produces tuberculosis in cattle. People are also susceptible to Mycobacterium bovis as a pathogen of tuberculosis. But the mostly spreaded pathogen of tuberculosis among humans is Mycobacterium tuberculosis. So if you remember, do you have a scar, do you have a sign on your shoulder?
Because of vaccination?
Yes, it is not because of generally because of vaccination, but specifically because of BCG vaccine against tuberculosis. And it is the only vaccine that gives you a scar. What it means? It means, Mycobacterium bovis is less aggressive than Mycobacterium tuberculosis. So if Mycobacterium bovis that is not as aggressive as Mycobacterium tuberculosis is the only vaccine that leaves a scar on our body, you can imagine how complicated is production of vaccine specifically for Mycobacterium tuberculosis. This is why we do not have it, because risks are not risks of production of vaccine specifically for Mycobacterium tuberculosis are bigger than benefits. So this is an example when medicine medicine as a science and as people, as scientists, are calculating all the risks versus all the benefits, and they decide to not apply. This is a response for anti-vaxxers that you don't appreciate risks versus benefits, and it is too dangerous for us to get vaccinated. That's false. It is very important to get vaccinated. Now, why though we apply this vaccine? Because it gives a little bit of protection, not too much, so it doesn't help you to not get infected, but it reduces complicated forms of tuberculosis, especially in children, that decreases severe forms and decreases child mortality caused because of tuberculosis. So it helps a little bit. But the best prevention method for tuberculosis is social changing. We need to work in our society. We need to educate our society. We need to explain to our society that it is extremely important which kind of lifestyle you have chosen for you and your family and your children. It is important to explain that if you've been born in such conditions, it doesn't mean you should die in such conditions. That means you can change something in your life. So if we would educate our society to develop financially, morally, culturally, it will be much better for incidence of tuberculosis than vaccination and treatment altogether. And as soon as more people will understand it, as soon spreading of tuberculosis will decrease, that town, city, country will develop and will prosper. This is regarding tuberculosis. Now, the next pathogen is diphtheria. The next pathogen is Corynebacterium diphtheria. That means it is rod-shaped, non-spore forming, gram-positive bacteria. Yes? Producing volutin granules. Volutin granules are extremely important for this pathogen as a source of energy. They are containing such substances as phosphates, and they are playing role of source of energy. For diagnostic, for diagnosis, for lab investigation, volutin granules are presenting also importance as differentiation of these pathogens from other rod-shaped bacteria. What is important to know about diphtheria? Also, all of us, I guess, are vaccinated against diphtheria, right? Moreover, if you are about 20 right now, I guess, you should get vaccinated against diphtheria. In that year, you've got 20. Maybe this year, maybe last year, right? You should. And if you didn't, you have opportunity to do that. Just go to our clinic and say, I'm already 20, but I didn't get vaccine against diphtheria. Could I get it here? And you can get it here. Why is that important? Because not just children can be affected. Anyways, children are mostly affected. They are mostly susceptible because their immunity is developing. So under the microscope, you will observe that Corynebacterium diphtheria are rods with two intracellular inclusions on both poles of bacteria that are chromophilic. What means chromophilic? They will absorb the dye even better than the bacterial cell itself. So how you differentiate Corynebacterium from other rod-shaped bacteria, for example, spore-forming bacteria? If we are talking about spore-forming bacteria, spores are not absorbing dye too much, either at all, either a little bit, but the bacterial cell will be more stained and clearly stained more than spore. First. Second, sometimes the spore will be present in bacteria, sometimes the spore will not be present in bacteria, sometimes the spore will be separated from bacteria and will be outside, solitary. and just in amount of 1. You will find it in any bacteria. If you find the spore in bacteria, no more than 1 in a piece. When we are talking about Corynebacterium diphtheria, all the time on both edges, so in pairs. Okay, this is how you differentiate Corynebacterium diphtheria. Now, it is very dangerous and aggressive infection, and mostly it is dangerous because its toxicity. Corynebacterium diphtheria is producing exotoxin that is extremely aggressive. If we are talking about cultural properties, it grows very good on blood agar, and it gives which kind of colonies? S colonies. Smooth, small, shiny with regulated edges, S colonies. Why on the blood agar? Because it is very susceptible, especially to humans' proteins. As nosology, you must be able to differentiate diphtheria from what? From tonsillitis. Because it can look similar, it can affect the same area. Both of them are bacterial infections and purulent and with production of pseudomembranes covering tonsils and soft palace. How we differentiate diphtheria from tonsillitis? First of all, diphtheria is giving more aggressive form of infection, but even tonsillitis can be very strong if you do not apply treatment on time. Next, in tonsillitis, these pseudomembranes, that whitish membranes that are covering tonsils and soft palace, will be as multiple whitish spots. Meanwhile, you can see here an example. In diphtheria, it will be 1 or 2 big spots, not a lot of small, but 1 or 2 big spots that are covering very big part of tonsils and soft palace. Also, in diphtheria will be very strong inflammation of upper respiratory tract that could lead even to asphyxia if we don't apply treatment on time. It is very important. As lab investigation, that's clear. We can take either as a specimen either swab from throat, or we can take the biopsy, because not all the time in swab we will find something, because it is membrane and inflammatory process is under that membrane. So sometimes we need to take biopsy. And after that we can make cultivation on blood agar, and we can also make some extra specific tests, including molecular biological investigations that will help us to find genus, species, toxicity, and other features, because not all the bacteria that are looking the same as Corynebacteria and Dyphteria, are pathogenic. We can have also some representatives of normal flora that also are looking similar. And as a treatment, first line treatment is antitoxin. Not antibiotic. Antibiotic is supportive treatment. So we start with antitoxic treatment because Corynebacterium Dyphteria is producing very strong, very aggressive toxin. And after that, after we neutralized the toxin circulating in our body, we start treating the cause. We apply antibiotic treatment. And treatment is usually with penicillinic group of antibiotics. Prevention, of course, on the first place will be vaccination. Because what you need to know about immunity against diphtheria. In some cases, vaccine gives antibacterial or antiviral immunity. What does it mean? I apply vaccine, antigens are entering in my body and are producing antibodies against this pathogen. If antigen is made of pathogen. But in case of vaccine against diphtheria, antigen is made of toxin, not of pathogen. So it is toxoid. It is toxoid vaccine. As a result, toxoid vaccine is a toxin that doesn't have its toxicity but has its antigenicity. As a result, my immunity is anti-toxic, not antibacterial. That means I am vaccinated. If I get infected, bacteria can multiply in my body, but it will not produce a disease because the toxin will be blocked, will be neutralized. That's clear. As a result, we do not reduce by vaccination. We don't reduce circulation of Corynebacterium Dyphteria in society. By vaccination against flu, by vaccination against COVID, by vaccination against variola, and so on, we reduce circulation of pathogen in society. But talking specifically about diphtheria, we do not reduce circulation of pathogen. We just reduce incidence of disease. This is why it is extremely important to vaccinate against diphtheria, because it can produce very aggressive infection that leads to aggressive forms and even to highly rate of mortality. And in childhood, we have DTP vaccine against diphtheria, tetanus, and pertussis. And in adulthood, we already don't have a vaccine against pertussis, against whooping cough. We have just against tetanus and diphtheria. And here is the last pathogen we will talk about today. It is Bordetella pertussis. It is causal agent of whooping cough. Bordetella pertussis is gram-negative. Okay. Which is the shape of Bordetella pertussis? Can you say it is coccus? No. Can you say it is a rod? Closer. Looks closer to rods, right? But basically, it is Coccobacillus. So it is oval-shaped bacteria, something in between rods and spherical shape, or kochi. It is Coccobacillus. And this infection, this disease, and this pathogen is one of, I would say, my favorite arguments for vaccination. And closer to the end, I will explain why. Just as you can see, talking about morphology, it is gram-negative. Here you can see how it actually looks under the microscope. By the way, this is why it is that important for us to have more types of investigations, not just microscopy, not just bacteriological, not just... We need to have more types of investigation, just because if you saw actually bacteria under the microscope, even simple light microscope is not able to make that magnificity that strong in order to make you sure about the shape of bacteria. Often you cannot understand, is it coccus or rod or what is this? More often you can understand just because their arrangement, because grouped together they help us to understand a little bit better their structure, and they are forming a bigger agglomerations that help us to make sure, yes, it is Streptococcus, not Staphylococcus, or yes, it is Diplococcus. And finally, yes, it is coccus. Yes, it is spherical shape. It is not rod shape. Bordetella pertussis is also airborne infection, is airborne pathogen. This is what is in common in all these three pathogens we are talking today. Mycobacterium tuberculosis, that has the mostly spread nosological form, pulmonary tuberculosis, airborne infection. Diphtheria, that also is airborne infection, and pertussis, or whooping cough, that also is airborne infection. Did you ever hear how sounds whooping cough? Did you? Some languages are giving a little bit more details regarding how it sounds, and in this context, I like how it is called in Romanian. In Romanian, it is called, let's say, popular name of disease is called donkey cough. Tu se măgărească, donkey cough. And when you can hear donkey cough, it sounds funny, right? It sounds funny just when you hear the name, donkey cough.
Really funny.
Yes, but it is not really funny, and soon I will show you. You will understand why. But really, from the first hearing, you think donkey cough? Okay. Did you ever hear a donkey? I guess so. Yes? Kind of that. With my voice issues, I can better make this sound. Well, the first thing that makes us to understand the importance of these infections, danger of this infection, and the importance of prevention. And here I would like to pay more attention, especially to prevention, especially to vaccination, but everything regarding cultural properties, treatment, and so on, you will read home. So all the data is here. But I would like to pay more attention to nosology. First thing that makes this disease that sad, that dramatic, that dangerous, of course, is the fact it affects children. And it is very it complicates the issue too much because of nowadays anti-vaxxer movement, right? It complicates so much. A lot of parents, a lot of mothers are refusing vaccination with very weird explanations. Some of them would be, we are not vaccinating and we are much healthier than other children. First of all, tell me please, please, which is the measurement unit by which that mother is comparing and proving that her child is really much healthier than others? Because you can see your kid every day, but you don't see others to compare every day. You can see them sometimes, periodically, but you pass all of your time with your kid, not with others, first. Second, even if it is a right statement, even if she is correct about the fact they don't get sick, it is not her achievement. We have such thing as social immunity. What it means? That means that still the majority of population are not refusing vaccination. And by the majority, we can say over 50%. That is not too much. But still, over 50% of population are not refusing vaccination. That means not too much sources of infection you have around, because most of kids, most of children are protected. Now, if her kid is hanging out with other kids and not getting infected, it is not her achievement. It is achievement of medical system and other parents who provided this social immunity. As long as you don't have a source of infection around, yes, it is not a big necessity of vaccination, but if everyone will stop getting vaccinated, what will happen? Sources will appear. Now, we have very small group of population for whom we really have contraindication for vaccination, lifelong contraindication. During pandemic, too much people like those appeared. Like every second had contraindication for vaccination. What? Of course, it was, we are talking about fake certificates about contraindication. Basically, very small population, a very small group of population, they have really lifelong contraindication for vaccination. And mostly, it is almost the only contraindication, lifelong contraindication for any kind of vaccination is immunodeficiency. So if you have innate immunodeficiency, or if you have AIDS, and I'm pretty sure, or I hope we don't have such people here, yes? I wish all of you are out of such issues. That means you don't have any lifelong contraindication for vaccination. Any other health issues are indication for vaccination.
Doctor, like me, for example, I was allergic.
Yes.
Since my child, but my family, my parents, they didn't refuse to vaccinated.
Yes.
Vaccinated.
Yes. So even if you are allergic, you can get vaccine, and if something happens, instantly you get a treatment against this allergic reaction, against anaphylactic shock and so on, and in few minutes you're safe. This is why it is important. Yes, this is why it is important after vaccination to stay a little bit, at least 15 minutes around the vaccination point, in order to make sure I'm not allergic. And I never know am I allergic or not until I will check. So, no any other reasonable points to refuse vaccination. Now, another thing is very soon we'll have a lot of sources of infection. We'll have a lot of sources, that means we'll have a lot of complications, a lot of severe forms, and a lot of deaths. Why it happens? It happens because often, last time, even doctors and medical staff admit doubts about vaccination. Did you hear some such doctors who are talking against vaccination? Do you know why? Because we don't have too much specialists in microbiology, in immunology, in epidemiology. We don't have too much specialists. Everybody wants to go in surgery, in dentistry, in therapy, in anything else, but not microbiology, not immunology, not epidemiology. Meanwhile, market is free and you can take all the money from this field. Think about it. While you're thinking, I'm taking. Okay, so and there you will stay in line. Could I also make a surgery, please? And you will not have enough experience. You will not have enough opportunities for development here. Please, but please don't come. Yes. There is higher competition. This is, please don't come and don't make me competition, yes? But still, if we're talking seriously, not too much specialists. Do you know personally more than one surgeon? Of course, bunch. Do you know personally at least one epidemiologist?
No.
Immunologist?
I don't know even one.
Microbiologist? Please. That's
This is bad, doctor.
it is extremely bad, and we should work on that. But some things are trendy. You maybe don't really like that specialty, but because it is trendy, and you can see the result immediately, and all the action is there. Students are going there. That means we don't have too much specialists. And it happens like it happens here. You are a lot, I am just one, and in order to overtalk you, I need to increase my voice. I need to talk louder, and I need the mic. I need the microphone in order to overtalk you. Meanwhile, you are not talking too loud, but all together. This is what happens in medicine. We don't have too much specialists who would respond. And other doctors are saying, well, we don't really know too much about that. This is why I would rather refuse vaccination. I wouldn't be that sure about vaccination. Why are you commenting in things you are not specialists in?
Doctor, even in my case, we didn't found the doctor, only one doctor in the city who is able to deal with such cases.
So,
one doctor.
Think about it.
In a big city.
Think about it. It is very important to have high diversity of specialists. Meanwhile, we have opportunities for development. We have everything. We need just people who are willing to develop. This is what we have. And here, please, a little bit of attention, because now you will see my main argument for vaccination, especially vaccination for children.
Uh-oh. There we go. Okay. It's okay. Okay, take a breath, Melanie. Come on. Almost there. There we go. Oh my. It's okay. It's okay. Yeah. It's okay. Here. Yeah. It's okay. Yeah. That's okay, sweetie. Yeah. That's okay. That's right. Yeah. It's okay. Yeah. It's okay. Oh, sweetie.
If you paid attention, the coughing is that strong, the upper respiratory tract is that irritated, the baby is not able to breathe in.
That's why even her lips were a little bit.
The entire process of coughing is just breathing out. And that final moment when you don't have to breathe out anymore, you don't have a place for breathing out anymore, happens this sound. You know? Because what happens? It is the total compromission of lungs and of the entire respiratory tract, and the process, the moment in which it is fighting for life. Actually, it is actually fighting for life. Now, and if you observed on the background, zoomer on the moment started beeping.
Yeah.
It is low oxygen. It is decreasing of oxygen. So whenever I am talking to someone about vaccination, and they say, I would never admit any minute risk for my kid. Please think about it. When you refuse vaccination, you admit a huge risk for your kid. Now imagine yourselves in place of that mom. You keep in your arms your baby that is not able to breathe, and you cannot do anything with that. Would you like ever to get in such situation? You are keeping your baby in your hands, and this baby has few months, no more. And you are not able to do anything for that kid. Would you like to get in such situation? Yes, we are afraid of 2 days of fever. Can you imagine? That could happen after vaccination against whooping cough. Yes, it gives about 2 days of fever, and the baby is a little bit apathic, is a little bit is a little bit sick. For me, it's okay to see my kid is 2 days sick just with fever, but is able to breathe and is able to continue living normally. This is what I would like you to keep in mind whenever you are talking about these infections, whenever you are making investigations, whenever you are giving the treatment, it doesn't matter which kind of specialty you will choose in this life, how you will contribute for society health, or even for your families. It is extremely important to appreciate all the risks correct and to talk to specialists and to take advice from specialists. It is very important. And as soon as all of us will be doing our own job, I will do my job, you will do your job, and now your job is listening and working and studying, yes? As long as everyone will take our responsibilities, there will be a higher chance for good results for everyone. Please think about it. Please check CMU, yes. Please please repeat all the materials you have 2 times a week. Once immediately after lecture, 1 day before class, 1 day before practical lessons. Wish you good luck.